All right. Do you want me to get started here, Kim? Okay. So, welcome everybody who's joining us for our grand rounds this month. This is May 2026 and the Ottawa River Integrative Mental Health Grand Rounds. I'm Kevin Vlack, registered psychotherapist qualifying. And today we're really excited to welcome Thomas Holmes as our speaker today. This came as a personal recommendation of Kimberly Sogi, the clinical director here. And Tom has a really interesting background. He's a social worker with an MSW from McGill and been working in the field for over 20 years, primarily at the Douglas Mental Health University Institute. And this work that Tom's been doing has focused a lot on IFS in how it's applied with dissociation and psychosis and severe mental health issues like that. So I'm personally really excited to hear what Tom has to share with us. And I was just saying that. So with that, I'll just turn it over to you and you can fill in any gaps that I didn't touch on there, Tom.
Yeah, great. Thanks, Kevin, and thanks, Kim, for the invitation. Just nice to see you again. Um, yeah, so first started. Okay, I worked at the Douglas 20 something years, 22 years or so, in the First Episode Psychosis Program as a therapist, social worker. First, more oriented, a bit of CBT for psychosis, then more ACT for psychosis, then compassion focused therapy, and then some years ago, let's say 7 years ago, there's a sub program at that clinic. And this sub program is like one of two really in Canada, which is it's for young people, 14 to 35, who are supposedly at risk of psychosis. But when you tease that out, despite, there's a research program at Yale and at that clinic and various places around the planet that has a real like reification of the idea of schizophrenia and like, oh, maybe we can prevent it. But when you tease out like what are the criteria, um, it's most people in those clinics are people with what gets called attenuated psychotic symptoms. So maybe they have a bit of voices, but they know like, oh, this is maybe my mind, or maybe it's not my, or maybe it's my imagination, or I am suspicious of the neighbors or whoever, but there's always a certain level of doubt or quote unquote insight. But when you tease it out, what you find is it's folks who have a good amount of trauma, often a lot. They're not diagnosed with complex PTSD because the DSM doesn't consider complex PTSD for political reasons, right? Because it's not very good for climbing the silos for status, either in research or in how services are organized, as you know, is so obvious. And the same thing goes even more so for dissociative disorders, which are as common as anxiety and depression, which is huge, but it's not, they don't have training in it. Psychiatrists have no training in dissociation, no matter, even if it's terribly common. And so there's a lot of people who have disorganized, who have just dissociation, but they're misdiagnosed with psychotic disorders because they talk about having voices, for example. So the first person I met who I knew, who I discovered, and probably were other people before that, who was clearly multiple, like with like DID, dissociative identity disorder, right? Somebody I was covering for the screener for our clinic. I was already working with the at-risk clinic, but then covering for a colleague who does the screening for the psychosis clinic. And, okay, you had a 15, 20-minute interview with a psychiatrist at the ER for McDonald's, fast food version of an assessment. And here you are, he gave you a quick diagnosis, quick and dirty diagnosis of schizophrenia because you were talking about voices, right? So, well, tell me about the voices. Just tell me about them. How long have they been there? And while they've been there since you were 6 years old, and mom had a major mental health issues and substance abuse issues, and men coming and going in your place, and you basically described to me that you were living 6 months more or less in a closet with a bucket and a bag of Cheetos. And in that lovely, horrible context, you had a voice come into you who was basically the archetype of how a mother should be. And that shook me to my core. That is so devastating and at the same time as a circumstance, but also brilliant as an adaptation, right? So not okay. And then another client, she, self-described as autistic and also had many different subpersonalities who showed up to help her manage different social circumstances that felt overwhelming and weird for her. And normally that internal team functioned well for her, but she was being overwhelmed by too much work and too much stress and too many substances to cope with all that. And so her inner community was getting really noisy, and the external stressors were also, so it was like overwhelmed from both sides. And in those circumstances, she would space out. So that kind of dissociation. And she basically was asking for help, like, can you help me find balance and better harmony inside? So I was like, okay, I got to go get trained in that. So did a bit of training in Gina Fisher's work, which is brilliant, absolutely necessary. And then from her to IFS, largely because it's like a nice stepping stone from compassion focused therapy, which can be very heady and a lot of psychoed rather than right into the experience. Right? And so that's been my main modality IFS for the past 6 or 7 years. Now, very appropriate for this at risk of psychosis clientele because they have like a functioning part of themselves, like a manager part of themselves, who overcomes the shame and the fear of being judged as crazy, but at the same time, to seek help. And at the same time, notices these parts of themselves that have trauma, that are giving trauma intrusions. Okay. Either as episodic memory, but also as, because, we know memory has different forms, and with dissociation, it's often like not wrapped up like a rope would be, like episodic memory plus semantic memory plus emotion memory and somatic and what to do memory. Usually these are all tied together, but with dissociation, they can be frayed. So you can have intrusions from somatic or sensory things, and don't have the episodic memory to make sense of it, as well as plain other kind of dissociation in the sense of depersonalization, derealization being the most common because it's most mild. You can have that with sleep deprivation, too much pot, um, panic attacks, depression shows up a lot, right? And it can be the feeling that reality isn't real, right? Or like that Radiohead song, this isn't real, this isn't happening, right? I'm not here, right? So I'm not here, I am, but here isn't, right? Or I am not here, so depersonalization. So derealization would be you're in the usual place, familiar place, but it doesn't feel real or doesn't feel familiar, or you feel disconnected from it, like there's a wall or a big thick glass plane between you and the world, or it feels foggy. Depersonalization is more to do, well, that could be about people as well. Like, you know, come home and mom doesn't feel like mom. Mom looks like mom, doesn't feel like mom. So there's this disconnect between the senses and the feeling, and that cognitive dissonance does require some explanation. Because so few mental health professionals understand dissociation, they don't get the help they need, so they stick often to get the relief from an idiosyncratic understanding. Now, if they're background to having more likelihood of this kind of dissociation can come from trauma. You're going to have the trauma intrusions. You're going to have the derealization. I'll come to depersonalization after. You're going to have the derealization, but you're also going to have this part of yourself it's kind of like an anxious what if manager that's trying to come up with scenarios, it's anxious, maybe pessimistic, looking out for danger, trying to come up with explanations for like why weird or bad stuff is happening. But if there's trauma involved, other people can be powerful, intrusive, threatening, right? And if that's the basis for those interpretations from the anxious part about the trauma intrusions, about the things not feeling real, it's easy to see how you can go from my world feels weird. I have some trauma. I've used some speed. And when I take speed, things don't feel real. But I haven't taken speed recently, but it still feels unreal. So maybe somebody's putting speed into my morning coffee, for example, right? And that anxious kind of part of ourselves wants explanations and doesn't like uncertainty, right? So even if it comes up with a bad explanation, like, oh shit, that means people are poisoning me, it has a sense of relief, right? But then and then there's another part, a more managerial part going, well, that's crazy explanation. These are crazy experiences, and I don't understand these emotions and where they're coming from, the trauma intrusions. And it looks at these experiences and explanations for them and goes, am I crazy? So when we offer them to the help-seeking manager part, it's like, I don't want to think I'm crazy. When we offer them like an explanation that helps the anxious part have like, oh, this is trauma-based, often that reduces both the anxiety plus reinforces like it makes sense to seek help. These people help, they understand, and we can, still orient towards life, like, with act and behavior type of interventions. And then it makes it safer to explore the trauma intrusions, but also make sense of the dissociation. And what's always weird with dissociation is even when it's feeling foggy or things like that, it's how to talk about that as a part also. I mean, you have it in schema therapy, right? Schema therapy complements IFS really well. And there's a bit more work. There's actually a good book on schema therapy for psychosis, if you want to check it out. But, there's this detached protector, right? In IFS, we talk in terms of proactive and reactive protectors, right? So proactive can be the managerial go towards, get things done, plan, help, seek help, give help. And then there's also the proactive but go away kind of protector, which is the anxious, the pessimistic, that kind of protector, right? This is the kind that can feed anxiety disorders or psychosis, most forms of psychosis, okay? And the same goes also for reactive protectors. You can have what firefighters, so they go towards, they fight, they rescue. Oh, I'm 5 years old and mom's stabbing dad. I have to go in and rescue mom and dad, right? And that becomes compulsive. But there's also the fire escapist, right? When you're getting too close to something, you'll space out. You'll have dissociation. You'll like, I've had clients who are supposedly at risk of psychosis and who are treated like, oh, they're probably psychotic. But when they talk about like, when he's like, somebody comes in, they say, well, I have 3 allies. And they kind of show up as voices. And I call them 1, 2, and 3 because I don't want to give them names because that's going to be too weird. There's me, there's number 3, which is carrying trauma from a really toxic relationship and makes me feel suicidal. You know, I have number 2, who's like the go do things, like some manager part. This is somebody who this is their language, and I was like, dude, did you read on IFS? Because it maps like right on there, really far out, right? And I've got number two is like get stuff done, is a behavior activation manager type, right? And I've got number one who's like shows up sometimes in conversations and was like, what were we talking about? He's the forgetter, the dissociator, right? Because number one and two are afraid of number three as he is, you know, like the main person that's that. So when it comes to helping understand even dissociation as a part, but it doesn't show up like a usual part. It may show up like a wall, like the 6 feet of earth that is buried in exile. It can show up as fog. I've had clients where it shows up as a cloud that talks to them, like there's nasty stuff coming out of the cloud. It can show up as a black hole, a sinking feeling in the body. There's many different ways it can show up. So it's useful to have these metaphors that symbolically connect with the person in ways that, really helps them connect to this part as a part. I often use the metaphor of, depending on the person, it can be like, how with like octopuses and squid, it can be like an ink cloud because that's a very protective mechanism. It's going to be like, all right, you can hide, have good camouflage, but if the predator, the shark, is about to eat you, you need to squirt to hide and then get away. The thing is, that's an automatic response with dissociation, of course. And as an automatic response, it doesn't give your functioning rational mind a memo to say, by the way, this is what I'm doing. So your anxious part is like, what the hell's going on? Right? And then it may try to come up with explanations like, have I been drugged? Um, is this really the reality? People will often talk when they have a derealization feeling of like, doesn't feel real. Like metaphorically, I'm in the Matrix or the Truman Show. And they're talking in terms of metaphor, but it conveys the feeling, right? Or like I feel dead, or the world is dead, right? Or gray, right? These are often considered prodromal symptoms for psychosis, but really what they are is they're kinds of derealization, okay? And if the person isn't helped to understand, like this is a protective mechanism to hide, to keep you insulated from an overwhelmed trauma, they're going to freak out about it. And they're going to lean on these metaphorical explanations as maybe it's not a metaphor. So if it is not a metaphor, like the Matrix or Truman Show, people, who is doing this? Where's the real reality? Why are they doing this? How come I know about the real reality, right? That And maybe I'm not supposed to know about it because everybody else seems to think this is reality or they're pretending it's real. So either they're in on a game or I have special knowledge that I know where this is not real. Thus, there's a real reality that somebody is controlling. But if I do, one, that means I'm special, which is a good thing. But it also means I might be under threat because they don't want me to know. We see this all the time in psychosis. Like there's this other reality that's more real than this consensual reality. It's more real, and I have special access to it, which is good, but at the same time threatening. Okay? See it all the time. So you can have easily from derealization paranoia, maybe grandiosity, because it's like, hey, I have this special knowledge. When it comes to what is considered first rank symptoms of schizophrenia, okay? Um, in other words, voices or inserted thoughts or sudden realizations of, there's this whole big scenario going on. If we could look at it from a trauma dissociation point of view, There is, again, this feeling of unreality, but it's about oneself. So depersonalization. You look yourself in the mirror, it's like you look the same. There's no change in the form, but the feeling is this different. I feel unfamiliar to myself. I don't feel real. That can be in a reflection in the mirror. That can be a body part. That can be about emotions. That can be about memories, anything internally. That can be things aren't real, aren't familiar, feel disconnected, um, or absent or overly automatic. Okay? So one can feel like an automaton or not there sometimes. Or an example I often use is somebody I was working with a long time ago, kind of meeting her initially, is this psychotic or not? Her thing was she and her boyfriend, she was in her early 20s, this is a while ago, and they were living together. She had a tattoo on her forearm, Chinese symbol for eternal love, I guess. Like, I didn't read Chinese, neither did she or her boyfriend. But anyway, so according to the tattoo artist. And so she had that on her forearm. So did the boyfriend. So when they were really close and fusional, it's like, oh, this is great. It symbolizes this deep, deep, deep connection. But when they were more like this, and it was a bit of a yo-yo relationship, right? When it was more like this, she felt disconnected from the symbol and thus by extension her forearm. It's like not hers, not anybody else's, but it's depersonalization. It's like not real, not mine. Okay. Fine. That's easy to understand from a dissociation point of view and like from the relationship context. Another thing close to related to her relationship context is when they were disconnected, they'd be having sex sometimes, and she'd be wondering, I wonder if he's having fantasies about this other girl that we both know while we're having sex, which is like, that's an easy thing to understand, right? Because, hey, that happens more than we'd like to admit, but that happens, right? But these things are being kept in parallel until one day they went together. So it's not only not her arm, what if it's this girl's forearm? If he loves her instead of me and is fantasizing about her, what if the forearm symbol of love is actually her, with her, about her, and it's not me? So that means my arm is not mine, right? You can see how the psychosis gets constructed. What happens often when we're dealing with people who've been diagnosed with psychosis for a long time is we're not there throughout the building process to see how they put it together, coming from trauma and or dissociation, plus an anxious mind, constructing an explanation. Okay. And then we just assume like Jaspers did, like, this is not understandable. This is too weird. But when you watch it get constructed, or the person has good enough memory to like if you interview people with various different ways of understanding depersonalization, derealization, including more elaborate evaluations for psychosis, like the EASE, EASE, or the EAWE, EAWE, the E's being examination of anomalous self-experience, which is parallels so much um, depersonalization, or the UE, which is world experience, the W is for world, which is very overlapping, like 80, 90% with derealization. Plus, both of them include major changes in existential, maybe metaphysical orientations. Like, what does this mean? Like, what does it mean if somebody can replace your body parts? And you can see how that's actually more a what if, but what if taken to an absolute extreme? Okay. Like the anxious part of the mind. What can happen, of course, like with anxiety, is that when you have like, oh, the explanation is she's doing this to me, right? It's not actually that he loves her instead of me. He still loves me, but she's taking over my body. Okay, there's a relief there, but at the same time, you've opened an ontological door that is pretty freaky. Like, what if that's possible, then what else is possible? right? And when she became pregnant, that really freaked her out, right? Because what if it's like, is this my baby or is this my pregnancy, right? So that will then get labeled psychotic, right? But you can see how that was actually built out of dissociation and anxiety without a better explanation for the anxious part to go, okay, this is dissociation. This is a part of me that's trying to protect me from serious kinds of other things. Okay. And when it comes to voices, what I always have done with folks, and I did it actually this week with somebody who's requesting services, which is to, and people are really good at this, like people who have voices, or they get a referral from a psychiatrist or a doctor or whatever. And how I do it is, let's say 2 columns with 3 rows. Okay, so let's say upper left corner, this is about verbal thoughts. Okay, so usually we have verbal thoughts, like, yeah, you're talking to yourself, remembering conversations, imagining conversations, preparing conversations, ruminating about conversations, talking to yourself, critical or just supportive or whatever kind of just voice, talking to yourself, inner speech, as Vygotsky would say. Yeah, fine. If you experience as you're doing it in your headspace, from you to you, right? And you experience it as thought, right? Column to the, say, the right is you can still experience this is from you, this is yours, but you're experiencing it acoustically or with sound. So there's this category that's been around in psychiatry for a long, long time called audible thoughts. So sometimes some of these thoughts will change registers from being thought to being sound. Most people are able to distinguish, like, oh yeah, sometimes I have audible thoughts. And then it gets called a voice. But they're able to distinguish it. Then you go down to the second row, let's say, of this, and you see, like, are there verbal thoughts in your mind that don't seem to come from you, but only exist in your internal world, right? Or maybe they're from you, but a part of you, right? It's kind of like you, like by your left hand. And a lot of people are going to say, yeah. Right? So then it's pretty clear you're already dealing with somebody who's relating to their inner world from a parts perspective, whether they identify as being plural or not. Okay. Whether these are elaborated into identities with names and other characteristics, or like this guy I was talking about, which is like, no, there's 1, 2, and 3 in my allies. Okay. They're all inside, they're just parts of me, but they're kind of distinct from me. But I don't want to elaborate more because then I don't want to have like my reality get more weird with thinking I'm multiple. Okay. And sometimes some of those parts that are experienced and talked about as parts of oneself can be experienced as in the room, out there, talking. Like I've had clients who have, it's not verbal. I mean, it's not psychotic-y, but it's, yeah, yeah, so and so, he's just waiting outside the door right now. Oh, okay, cool. Right. Or they're in the room. Yeah, one of them shows up sometimes in the room out there, sometimes in here. Right. So it's intensification of internal imagery. So it changes registers some, but that's still like from oneself. Okay. And I always ask, well, when they are doing that, do they give access to other people out there in the world to your internal world? And it's almost always no. Sometimes people can have audible thoughts, like I was saying before, right? That people will wonder, especially if they're anxious about, like, there may be some social anxiety, it might be bleeding into paranoia, especially if there's also derealization, which, like I said, can feed into paranoia. Um, if you're hearing some of your thoughts, especially ones you really don't want other people to hear, you may be worried that other people can hear them. And then you may be scanning your environment to see, like, did they hear that? Huh? And then, people react to you in a weird way because you're looking at them weird, right? So that feeds into a kind of paranoia sometimes. Now, the bottom row is still experienced as thought, not from you though, but also not from somebody inside, maybe somebody out there in the world. That's the usual category in psychiatry called inserted thoughts. Okay. Now that somebody out in the world, the person may go, yeah, I know it's just my imagination. Or, but it can still be distressing. Um, and maybe it's somebody in the world that they know, right? From a friend or a coworker or a family member or something, or a neighbor. They may go, yeah, it's probably just my imagination. Or they may go, yeah, I'm actually having telepathic communication with so and so. And that's inserted thought. It's still experienced as thought, but sometimes it's also heard as an outside voice. Technically speaking, that is auditory verbal hallucinations or even illusions. Okay. More illusion if there's background noise, like people talking, like crowds talking, or the shower noise or white noise, right? Um, it's a sometimes useful question, whether it's psychotic or not. And my depends on what you mean by useful. Any of these things may or may not respond well to an antipsychotic. Okay? My experience in observing clients is that whether they or not they have these auditory verbal hallucinations or inserted thoughts or parts of themselves that are experienced as parts or, either inside or outside or audible thoughts, those things don't actually respond very well to dopamine blockers. Sometimes a bit, maybe at really high doses, but then they're sedated so much that they don't have access to a lot of self-energy, right? The dopamine blockers, because if we think about what does dopamine do other than movement stuff, it's a lot about exploration. Okay. So exploration in terms of anticipation, wanting to go towards the seeking molecule in Jakob Panksepp's work, or anticipatory pleasure from drawing a blank for his name. There's liking and wanting, right? It's more to do with wanting. So exploration and moving towards something. That is in terms of behavior, especially in substance abuse or impulsivity, but also in terms of mania, when that is really cranked up, but also in terms of what ifing when it comes to especially psychotic levels of explanation. Like this young lady I was talking about with like, what if it's her and how does she do this? And how am I, what if it is her replacing my organs somehow? How does she do it? Why? How bad can it get? Right? The dopamine blocker actually works better for calming that over explanation. The metaphor I use for that is like a spider wanting to make all sorts of big connections between contexts that usually would not be put together, or there's be no, that like, the person's able to say, no, there's no connection between these contexts. Like, feeling a bad interaction, but somebody at home and then somebody at a coffee shop and then somebody 2 weeks ago, right? Normally you'd go, I'm in a big city. These people don't know each other. But when the spider of making too many connections is overactive, it's going to make all sorts of connections. And not only does a spider web get too big, unlike spiders who don't get caught in their own webbing, we do all the time, psychotic or not. That's just how humans are. But more likely to get stuck if, on that level of things, because, it's all on a continuum, whether we call it psychotic or not. And the dopamine blockers of antipsychotics help with the spider calming down, or the person going, okay, I can see the web. It's no longer getting constructed. I no longer see the connections, but I'm pretty sure it was still there. So, but it gives enough space for the person to not be pulled continually into the psychotic process and maybe look at it and like, oh yeah, I saw how I constructed that. That's not very helpful. Yeah, Kim.
Yeah, thanks so much for this, Tom. It's fascinating. And what I'm hearing you say is it sounds like a lot of time these examples you're giving, people have insight into what's going on. And I'm also thinking about all the people I've sat with where I'm like, you're completely inside this part. And me
Yeah.
inviting you to have perspective on it is not probably going to go over real well with all the protectors in the system. Can you talk a bit about how
Yeah.
you work with folks who are really blended with these protector parts?
Yeah.
Yeah.
Yeah. Excellent question. Yeah, because, even before I got into IFS, there's a guy who's like just not insightful at all, right? And not psychologically minded at all, right? So what, and but a good pot smoker. So he just sent help to get pulled into these sticky scenarios. So you know what I did with him? It was a bit of like an act kind of diffusion thing. I was just asking him to notice, like he's on the bus going to work, right? And these things are elaborating while he's on the bus. So I just asked him, could you notice your mind making the connections? And he would, right? I didn't ask him to question the connections, say they're not real, say that, whatever, like just notice if you're making all sorts of connections. And, most of the time, even when people are really pulled into this scenario, they'll be noticing, like, yeah. And I often use metaphors just because my mind works in my metaphors. Like, I would use, and I still use it a lot, the metaphor for blending with a scenario, psychotic or otherwise. You remember like the alien movies with the larva stage like stuck on their face, like like fingers and a hand and whatever. It's like, do you ever have the feeling that this whole scenario, true or not, is like the friggin' alien? And you would be nice just to have a little bit of space from it. It may be real, but if you have a bit more space, you can engage in other things, right? One guy I was working with, and he was on a super low dose of Abilify, okay? And he didn't have derealization, depersonalization, but he had a good amount of paranoia. And it was a scenario where somebody was trying to blackmail him because he was like on internet and on some sex site. And the person said, "Oh, I've got a video of you using this website, and I know where you work, and I know your connections, and I'm going to blackmail you for money." So the guy freaked out, right? And to the point he was feeling like suicidal. And so, he was on a low dose of Abilify. He gradually went back to work. One of the things that we did for him, we try all sorts of different tools, right, to get a bit of space. And it wasn't so much about it was actually asking him to notice his mind, like his worry mind, making like observing like who's doing what. Like it's like really checking through the ideas of reference. Like, oh, that person's interaction has to do with me, right? And having them sort of notice that process, not about disbelieving it or anything like that. And not the usual, I mean, you can do sometimes for certain things, you can do the CBT reality testing, but not always because they get defensive, right? Because that means like, oh God, I've got enough to deal with. Now you're saying I'm crazy too. Like that's just, they're gonna hunt. And what was interesting with this guy is like, I asked him like, because the way he was describing it, you could tell like there was an impulse and he's like really having to know, right? And I kind of went, I had a hunch with him. It's like, it feels almost addictive. Like you gotta know, right? It's like you can't let it go. Like who knows what and what sign are they communicating with each other that means like some hidden thing that they know, the secret that they shouldn't. That makes you feel terribly ashamed. So what I asked him to do is like, well, because it's like an addiction, have you ever smoked and quit smoking? And it was just on the hunch. And he said, well, yeah. It's like, okay, cool. Well, you're not smoking anymore. How did you do that? Because that's really hard to do. Like it's on the top three of addictions. It's really freaking hard to stop. So he described, first of all, like, well, first I fought the addiction. And I'm like, aha, like my act brain is going, aha. And then he was fighting the addiction. Of course, he ended up smoking more, right? So it's like, okay, well, that's good that you noticed that and that it didn't work. Well, you did succeed in the end. Well, what did you do? and this is my addiction counseling thought coming in too. And it's like, well, I noticed my pattern when I would smoke, like, at the breaks at, lunch, lunchtime, mid-morning, mid-afternoon, whatever. And then I knew that that was kind of programmed in me, and I'd have a wave of urge to smoke at those times, but then I didn't. I put it off. I wasn't fighting it nor giving in to it. I put it off. So the delay thing in addictions or any kind of impulsive behaviors is really effective, right? We know that from the data. So I'm like, and you succeeded in doing that? You could quit smoking by doing that? It's like, yeah. So, okay, awesome. Now let's take that skill set that you had there, that you proved to yourself works on a really hard to do addiction, and do the same thing when you have the urge to figure out like who knows what and how are they communicating that to each other and elaborating on all that scenario. And when you have the urge to figure that out, do the same thing, delay it to a time of day when it's like you may engage into it a little bit, but intentionally, not automatically, but not for, more than half an hour. If you choose to engage, like you invite that part basically to engage in that process for X amount of time, but not at work, not right, some time of day when you have enough ability to go, okay, thanks, start, half an hour later, stop, we're good for now. And it kind of contains it, right? Gives a feeling of control, acknowledges the process of that part, but doesn't let it run the show 24/7. Okay. And he did that, and it worked. And it wasn't about whether it was true or not. It was just containing it. So it was reinforcing his self energy. I like to add to the various C's that are already in, you know, right? One is containment. So it's containing all the parts, but it's also containing them like one at a time. So you're not running the show all the damn time or bouncing back and forth, right? And also consistency. Like you offer the same time to those parts every day to check in with them. Okay. And you offer them compassion and clarity, like, yeah, okay, I see why etc. And after a couple of years, like in the program, we would have people who had, done well in their recovery speak to family members, like, well, what helped and what didn't help. And I asked him, like, well, if he wants to do that, because he was like doing great. And he was like, well, what do you want to let them know? Like, what was helpful? And he said to me, one of the nicest, coolest summaries of what psychotherapy can be that I've ever heard. This guy's, like bright guy. And he said, well, Tom, here's the thing is like, I was really pulled into this scenario big time. And what helped is you did not try to take that scenario away from me. You offered me another scenario like that was engaging in life, meeting the same needs, because shame, you don't want to be rejected. So, and a sense of mastery, you don't want to feel dominated by other people or their possibility of rejecting you, etc. And he was reconnecting with community. He was into kite surfing, which is like, dude, do more of that. That's just awesome. You want to be in the now, you got to be, you're like in the flow, like literally, but also flow states, right? And he really engaged in those things. And he said, look, you offered me a different scenario. So every time there's this temptation to go down that old scenario, the metaphor of like a path well worn, it's very easy to go there, but I know where it takes me. I remember where it takes me. And I remember this other pathway that's where I want to go. And every time I just have to choose. So it wasn't about what was real or psychotic or anything like that. It's like, how functional is this for what you want, like for your values, but also for helping those parts that speak to those needs have their needs actually better met in reality, but in a positive way. And then I got a call from, and this was like 15 years ago or something. And then I got a call from, I think it was 2 years ago. He just like, pocket called me by accident. I'm in some meeting. He's like, oh, hey, right? And this is like, I don't know, 12 years later. And he's like married. He's got a kid. He's doing really well. He's not on any medications anymore because like he was useful as a leverage for that process, right? And once you've learned that, like, yeah. I don't need to go down that path. This is a much healthier path for me. He kept doing that. Some people, they need that leverage all the time. Not everybody. Does that answer your question in a roundabout way?
Yeah, like I really, we have such similar trajectories in terms of our development as therapists. Like I'm seeing the ACT parts and the social mentalities parts and the
Yeah,
IFS stuff. And I really appreciate how there's just such a lack of um, shame and judgment on the parts for doing what they're doing. And that seems to be a pretty key ingredient in what the kind of change process is that you're
absolutely. Yeah,
describing.
yeah. It's totally non-pathologizing because it's like the thing is, right, with manager parts, be they anxious, pessimistic, or like get on top of things, figure stuff out in a positive way. They don't like if they're in the negative, well, negative in the sense that they don't want surprise. They want a feeling of control. They want a feeling of predictability. They really don't like bad surprises. If you've had a lot of trauma or a lot of disappointments, surprises are always bad. So you're definitely trying to reduce those, right? So you're coming up with scenarios like who, what, etc. What ifs, right? Be they ruminatory or anticipatory. And he didn't have dissociation, but so many people I've worked with, when they understand the dissociation, it's like, oh, yeah, you're there again, my foggy friend, right? You're trying to numb me out, even without substances. But thanks, but I can gently, do you give me permission to gently lean into the thing you're trying to hide? And if they don't, then it's like, oh, I'm not going to push you. I'll lean back and I'll take the time for you to see that I'm a trustworthy person, you know? And that's a lot because manager parts want to get it done fast. So sometimes it's about those manager parts saying, I have very strong mapper part. I like to combine models and it's like fun. It's not just an anxious thing, it's just fun. So I always say talk about my mapper, kind of like from Dora the Explorer, right? I always talk about the mapper going like, yeah, mapper, I'm gonna let you talk to this person's mapper because they want to have a bit of a lay of the land before they go onto the territory. And then we'll do a shift into you're cool with going onto the territory, and we'll see what kind of protectors come up. Quite likely, because we all have the same layout, just different extremes, different way they show up. If you get too close, either there's a big guardian with an axe who's going to come out of the cave, or whoop, fog, and you have no idea where the hell you are, right? Or an avalanche, and you're like, one really cool person I've worked with, they have a exile that had a lot of trauma. And that one is locked in a giant block of concrete, right? And it's always one of the key things in IFS, like in schema therapy, just even if the languages are different, is distinguishing between the parts, especially the exiles parts, and their burdens. Because managers don't see the difference, right? So for this person with the exile, traumatized part, like so worried, like, am I like the abusing dad? Right? Are my genes, do I might poison it even on the genetic level, right? Feeling that level of empoisonment, right? And that's, an anxious part trying to figure that out that doesn't see that it fuses the blended, it blends really the burden and the exile. But so it takes a lot of education and reassurance for manager parts, like working with them long enough, checking in with them again, back and forth, to help them see like, oh, conceptually that poor part, and this is where compassion can come in. It's like, oh, that poor part, they don't see that they're different from the abuser. Maybe they've internalized the abuser, but maybe they have this scenario of like my genes or my behavior, etc., or angry impulses. So it takes a lot of work with these kind of protectors, back and forth. Not just the reactive ones, but really a lot of work with the proactive ones. Yeah. Yeah. Any other thoughts or stuff coming up, folks?
Yeah, I was just going to invite if anybody else out there in the audience has any questions, please feel free to speak up. Um,
I have a question about first onset psychosis itself. Generally speaking, it's something that happens fairly young. Um, if somebody's been fairly functional their whole life and are now presenting older than 50, let's say, with either paranoid or dissociative type of symptoms, what are the chances it's actually just finally breaking down after a lifetime of trauma? Or at what point do you think, okay, is there an early onset cognitive issue that could be because things like Alzheimer's and things also have often have paranoid elements to them.
Yeah. Great question, Laurie. Thanks. Well, it is important to tease that to do a good, and doesn't happen enough in psychiatry. Like one of my Facebook friends, he's a psychiatrist, like they'll does it like from let's say 8 to like 80, right? Really good, does a really good blood workup. Okay. It's often not done. People just assume, okay? And if somebody has metabolic stuff, I've had clients or people who were seeking out help, but finally, anyway, they went elsewhere. They've had like an immune reaction from COVID, like an autoimmune reaction from COVID, where their system is attacking certain neurotransmitters that calm the nervous system. Okay. And that needs to be tested for. And it's possible to test for that stuff, but it's often not done. And so it can happen. There is a wave, especially for women, because who are protected by estrogen for a good chunk of their life until menopause or perimenopause kicks in, and then it comes through. Okay.
A- And how do if someone's coming to you and they're paranoid, they're suspicious, and you say, I wonder if it's your hormones, or I wonder if it's a reaction. Did you ever have COVID? Maybe you need a blood test. We're as psychologists, we are not allowed
Yeah.
to refer to psychiatrists. Like psychiatrists don't take our referrals. How do we get people who are having suspicions and whatever to
Yeah.
do these kind of things without making, again, not dismissing and saying, oh no, you're not paranoid, you just had COVID. Like, what do you do?
Yeah.
How do
Well, the thing
you?
is, they would be paranoid. It's just
Yeah,
the
right.
underlying root cause is a different
Right,
one.
right, right. Not you're not paranoid, but no one's out to get you. You just had, COVID got you. That's what happened. Like, it just because
Yeah.
you don't. Yeah, I agree with what you're saying 100%, that it works much better to say, I understand what you're thinking and feeling. How is it working for you? Does this serve
Yeah.
you? Where are you trying to go? How can you get there better?
Yeah.
That's definitely a better way to go. But when it's really actually a biological thing,
Yeah.
and you're not a doctor and you can't refer to psychiatrists, and if you do, they'll say, well, you just think I'm crazy.
Yeah.
Um,
Well, often, I mean, what can if they have a family doctor, hopefully, the family doctor can do some of those blood tests, and you can like, can I have your permission to speak with the doctor? And you know, like I will explain the experiences that you're having, but I also want to make sure that you're in physical good health because you may not have had all of this blood work or whatever else checked, right? And or maybe haven't had them all checked or have had some of it checked, but not all of it. So family doctors can run those tests, right? It is stupid that the only way to access psychiatrists it's hard to access them without going through a family doctor or the emergency, first of all. That there are so many systemic problems. It's ridiculous. Okay, really, really problematic. So, but family doctors might be a way to might, as a way to recommend like, hey, could you run all these tests? Because one of the things that happens a lot is people don't like there can be vitamin deficiencies. Okay. There's a lot of people, like, even when the clinic where I was working is like, this person's vegan. you want to test for B12, but also the other way to test for B12, because you can have B12 masked, a B12 deficiency masked, because if you're asking just for B12 levels in the blood, you may not be getting to an actual deficiency, right? Because there's various ways to test for and B12. Look, Sandor Ferenczi was like one of Freud's main, like his best clinician, but also rebelled against Freud because, like, dude, the seduction theory, they were abused, right? And Freud kicked him out. But Sandor Ferenczi died a few years after that from pernicious anemia, from a B12 deficiency. It can be really, really bad. So there's a bunch of things that need to be tested for. Um, when it comes to, Alzheimer's, it's also, a doctor will be able to like, let's refer you to a neuropsychologist, right, to test for some of these other things, because there's going to be other things showing up probably, right? It's also really important to test for like, is this person living in a safe, like when we think that person has paranoia, we really need to check to see, are they in a safe place for real, you know? And one of the interesting researchers on CBT for paranoia in particular, Dan Freeman, he has a really cool program called the Feeling Safe program. They've even done it online with online groups. It doesn't directly address the paranoia, the suspiciousness. It addresses sleep hygiene, worry processes, various things like this, all very indirect, and it works just as well as anything else, like actually better than anything else. But, that's when there is no biologically obvious thing. I'd also have to say that, like, I would say like the model I'm kind of coming from an IFS perspective is largely anxiety, trauma, dissociation, right? Like we see with chemotherapy, a certain kinds of overcompensating parts or modes is, like I was saying, like, oh, I'm so special, I have special knowledge about this other reality, right? Or my explanations are metaphysical. That's a whole other, it's like maybe not a paranoid thing, but like wowness to it, right? So what's interesting with that is a lot of times people have felt very isolated. And we know that one of the biggest risk factors for any kind of psychosis, disorganization symptoms included, is loneliness and isolation, right? So if you're getting negative attention, it's better than none. If you have like wow attention because you're the center of the universe, well, that's got to feel good. Mhm. And especially if it also helps to make sense of like, I'm not sure if this other person next to me is real because your derealization is so intense. And you're basically in a solipsistic mode. Like, I'm maybe the only consciousness in the universe. One, it feels terribly lonely, but then you flip it over and it's like, oh my God, maybe I'm God. But shit, now I have a whole bunch of responsibility. Right? Always a double-edged sword. Yeah. Does that answer a bit of your question? Plus adding other stuff?
Well, thanks, Tom. I've personally really enjoyed hearing from you today. We've done an hour, went by pretty quick. Hopefully for everybody else watching, I just yeah, I've really loved hearing from your personal experience. Some often uh, these you read about these theories and stuff like that, these modalities, and just hearing the real world experience is so much more important, I think, for all of us. And so yeah, thank you for sharing all your experience and
Yeah, thanks.
yeah,
Thanks for having me.
of course.
Yeah, yeah, yeah. Yeah, metabolic stuff. Oh yeah, because that's like Lori, you could bring back to the yeah. If somebody has, yeah, that needs to be checked.
Thank you
And
so much, Tom. That was really amazing. And I know that you have an interest in kind of metabolic psychiatry and diet and all that too. So it'd be really great to hear from those parts of you as
yeah,
well
sure.
someday.
At some point, yeah. Thanks, everyone. Really
Thank
great
you.
chat.
Hey, Tom.
Thanks. Bye.